At the outset, I'd like to thank the organizing committee of WeCare for inviting me here, and I'm happy to see that we've got such a huge turnout. Now, as a counterpoint to Hari's talk, I'm going to speak about assessment of delayed puberty in girls. I'm going to give you a virtual walkthrough to a case. This is a typical case scenario which I've had, a 15-year, 3-month-old who's been referred for what is hypothetically considered a delayed puberty. She was born full term by normal vaginal delivery, did not have any history of birth asphyxia or pedal edema in the neonatal period, which is of some significance if you're trying to elicit a history of delayed puberty. The subsequent development was normal. She did not have any chronic disease. When we delved into the family history, she did not have any history of delayed puberty in the family. She is short. She is not by definition short, but she has always been grouped among the shorter children in her class. She has one elder sibling, a male, who has normal growth and normal development of secondary sexual characters. He is not into really intensive physical activity or sports. And very importantly for endocrinology, she does not give any history of anosmia, at least on questioning. And when I examined her, this is what I found. Her height is now 150 centimeters, which puts her at around 25th to 50th. That's a typo, sorry. 25th to 50th centile for the age. The weight is 55 kilos at 50th centile. She is not a typical case of delayed puberty. She does have some amount of breast development. She's got development of axillary hair as well as pubic hair. Does not have goiter. She has no pallor, and at least on gross physical examination, she does not have what is called a typical Turner's phenotype. To summarize, we have a 15-year, 3-month-old who is referred for what is not exactly delayed puberty, it's more fitting into primary amenorrhea, who is slightly short for her age. She has breast development but has not attained menarche, and the mother could not give us any temporal history as to when she started her breast development, which is very important when you are assessing a case of delayed puberty. So this is where I think most people, most clinicians, both endocrinologists, pediatricians or gynecologists would go into what I'd call the Alexander Pope method of management, where you rush in where an ordinary angel would fear to tread. You just start off with doing a gonadotropin, do an estradiol, prolactin, thyroid profile, karyotype, and there are many people who are nowadays, now that genetic testing is very inexpensive and easily accessible, people are going in for exome sequencing and panels also. Even if you don't know what panel to order, the lab person will tell you, the genetic lab person will tell you what panel to order. So do you think this is the right way of approaching a case of delayed puberty? Definitely not. More often than not, it is going to lead you into bigger confusion than what you started with. I prefer what is known as a nuanced approach, a more subtle approach which deals with delayed puberty in a stepwise manner. We have to get a few questions answered first before you actually go into the investigation part of delayed puberty. The most important question is, what is the definition of delayed puberty, which is still a very contentious question. With the evolving secular trends in puberty, exposure to endocrine disruptors, increase in body mass index, and the increased nutrition which we have seen since the past 50 to 60 years. This question, what is precocious as well as what is delayed puberty, is something which has been constantly changing over time. We've had changing goalposts. The second question, which is very pertinent to this case, when somebody has had breast development, has this puberty been stalled? Which conditions do we need? There are a few physiological conditions. There are a few very mild conditions which don't actually require treatment, which need to be ruled out. Before we investigate further, a lot of times when we investigate them, they can be indistinguishable from the classical pathological conditions which can cause delayed puberty, but which these conditions do not need treatment, and these need to be ruled out further. Do we need to look for anything specific in examination? I have shown you a basic examination of a child who's presented with the OP. So when you are dealing with a case of delayed puberty, what do we need to look for further? And what is the stepwise sequential manner in which you go ahead with investigations rather than ordering a generic panel of investigations? The first question, delayed puberty, what exactly constitutes delayed puberty, is based on the population normative data. The most commonly given definition is absence or incomplete development of secondary sexual characters by an age 2 to 3 standard deviations above the mean of onset of puberty. Some guidelines give it as 2 standard deviations, some guidelines give it as 3 standard deviations. Most of the time, this is based on country normative data. Right now in India, there have a few small region-specific studies, but we do not have a single large unified study or a single country-wide cross-sectional study which has given us normative data. So we do not have India-wide normative data, so we still go by the Western data, which defines delayed puberty as absence of breast development by completion of 13 years of age. You need to complete 13 years of age, and if you do not have breast development by then, it is essentially considered delayed puberty. A lot of children will actually develop pubic and axillary hair, but this is not included because this is symptomatic of adrenarche, which is adrenal androgen production, which causes pubic and axillary hair. The usual chronology is generally during puberty, the first development is stellarche, which is the breast budding. Within 6 months, this will be followed by pubic and axillary hair development because the estrogen produced by your ovary stimulates the adrenal gland to produce the adrenal androgens, but this is not always happening in such a sequential manner, and you can have an adrenarche which precedes stellarche. So only presence of pubic and axillary hair is not indicative of onset of puberty. The next question, which is very germane to our issue at hand, is has the puberty been stalled? By common consent, the definition of stalled puberty has been menarche 4 years after the onset of breast development. And this assumes a lot of importance in the evaluation of puberty. This can indicate partial hypogonadotropic hypogonadism, where the pituitary produces enough gonadotropins which produce enough estradiol so that you can start on the road to pubertal development, but it does not have enough fuel to take you to the completed pubertal development. Hyperprolactinemia because of a prolactin secreting tumor or a CNS tumor can suppress the gonadotropins and cause an arrest of puberty, the so-called typical pubertal arrest, which is also seen in people with pituitary tumors. Other CNS tumors can also cause suppressive effects, especially because of the mass effects, which can cause this kind of a picture. The same goes true for inflammatory diseases, and pituitary trauma, is, especially in accidents and falls, is one of the very well-known causes for stalled puberty. The other conditions, like I told you earlier, physiological conditions which need to be ruled out before investigating further, the commonest of which is what is known as a functional hypothalamic amenorrhea. This is caused by an aberration of the pulsatile release of GnRH from the hypothalamus. The most important pathology implicated in this is an increased pulse of LH frequency, which prevents a proper pubertal development. This has 3 common variants. Can be because of weight loss, especially in people who are into extreme sports. Can be because of extreme stress. More often than not, it is exercise related, especially gymnasts and long distance runners. The pathology implicated in this is a hyperactive HPA axis, which constitutes what is called a female athlete triad, where you have less eating, amenorrhea, and osteoporosis. There have been multiple studies on functional hypothalamic amenorrhea. We've still not got a proper idea as to what constitutes a functional hypothalamic amenorrhea, but the commonest endocrine abnormalities we see are an increased ghrelin, a decreased leptin because of a decreased fat mass, increased CRH because of an HPA axis activation, increase in beta endorphins, and an increase in allopregnenolone levels. This is a very simple entity which does not require any treatment. If you would actually investigate it, the only thing you are going to see are a low LH, low FSH, and a low estradiol, which is indistinguishable from what you'd see in a classic case of hypogonadotropic hypogonadism. But the difference here is GnRH stimulation will cause a rise in LH and FSH. This doesn't require any treatment. Just stop the excess exercise, start eating, increase your fat mass, and the periods will start. You will have your menarche within 6 months of normalization of your general status. The second question we have to ask ourselves is there a familial delay in puberty? The commonest cause of this is a constitutional delay in growth and puberty, but it is not as common in girls as it is common in boys. Still, up to 5 to 10% of the girls who present to the OP with a delayed puberty can present with a CDGP. Sometimes isolated GnRH deficiency, especially the milder variants where puberty is stalled, can be indistinguishable from a CDGP. More often than not in CDGP, we'll get a history of either parents having a CDGP or one of the siblings having a CDGP. What you'd call the classic late bloomers who don't grow well in the first few years of life, who suddenly start having an exponential increase in height around 15 to 16 years of age, and they can have their menarche at 15 to 16 years, slightly later. More often than not, both conditions have an autosomal dominant inheritance, and when somebody presents at 15 years of age, it is almost impossible to differentiate both these two conditions. As far as the examination is concerned, these are the specific symptoms we look for. Anosmia, which is classically seen in some variants of Kalman syndrome. Look for the Turner's phenotype. Do the Prader staging. Prader staging wherever it's possible. It's very easy for women, slightly difficult for men, especially when somebody comes at 15 years of age. Makes sense to have an assistant, a female assistant, who can have a look at the child and who's trained in doing the Prader staging. And look for facial dysmorphism, especially midline defects like cleft lip and palate, and midfacial hyperplasia, which can be suggestive of pituitary hormone deficiency. This is what we call the typical Turner's phenotype, where you have a short stature. Classically, the most important things are webbing of neck. They can have pigmented nevi, peripheral lymphedema at birth. This is the reason why you always have to ask for a history of edema at birth. They have a wide carrying angle and a broad chest. But if you have actually studied female ifshits, you would have understood the textbook of pediatric endocrinology. There is absolutely no correlation between the genotype and phenotype in Turner syndrome. You can have a patient with a flagrant exophenotype, exogenotype, without having any of the classic phenotype features of Turner syndrome. And this is how you do the Prader staging for the breast. Axillary and pubic hair staging is similar to what it's seen in the boys. The first investigation, contrary to general perception, is an X-ray of the left hand and the wrist, which gives us information about skeletal maturity. You generally do have some amount, up to 20% of delay in bone age in children with CDGP. This can be very delayed in hypothyroidism. Classically, hypothyroidism is described to present with precocious puberty, the so-called Van Wyck-Grumbach syndrome. But many cases actually do present with delayed puberty. The bone age is also delayed in combined pituitary hormonal deficiency. This gives us a good amount of information, but it is not going to help you distinguish between the different causes of delayed puberty. Then we go on with the general laboratory tests, because any problem in the child, any malnutrition can actually manifest as a delayed puberty. So we do the routines like the blood count, ESR, the creatinine, the liver function. Celiac screen, not much of importance in South India, where it is almost non-existent. A big problem in North India. And then coming to the crux of the issue, this is where the endocrine evaluation comes in, not at step 1. Since we are angels, we fear to tread. We do all this and then we come to this step. Look at the gonadotropins, LH and FSH. Look at estradiol. Very important, don't forget to do a prolactin, because hyperprolactinemia is a very common cause of either delayed puberty or a stalled puberty. Thyroid profile and karyotyping. Any short girl who presents to the OP with delayed puberty has to be evaluated for Turner syndrome. GnRH stimulation testing for delayed puberty is not recommended. It's quite useful in precocious. Delayed puberty, there are many studies, but the data is pretty mixed. There are some studies which have actually advocated using buserelin testing, but even for that, the evidence is very limited. Additional testing, this is where we have our additional testing. Exome sequencing comes in after you diagnosed it, especially in cases with hypergonadotropic hypogonadism, where you suspect some ovarian insult. MRSLA, especially in people with hypogonadotropic hypogonadism, where you suspect that they have a pituitary tumor or you suspect a combined pituitary hormone deficiency. If your lab is well equipped and you suspect a Kalman syndrome, you can go with what is known as a smell kit. A smell test using a smell kit of various substances which need to be smelled by the person to evaluate how impaired his sense of smell is. More often than not, don't forget to look for an iron overload, because beta-thal trait and beta-thalassemia minor are very common in the general outpatient setting, and they are treated for years together with iron supplements, which can lead to this kind of hemochromatosis and hemosiderosis. And stimulation testing with kisspeptin is being indicated in a few recent publications, but because of the difficulty in getting kisspeptin and because of the fact that we don't have a lot of evidence right now for this kisspeptin testing, it is still in its infantile stage in diagnosis. As far as the therapy is concerned, we generally look at treating a specific cause. If you find it, you've got iron deficiency anemia, treat it. Hypothyroidism, treat it. Hyperprolactinemia, more often than not, institution of cabergoline will help in progression of a stalled puberty. Functional amenorrhea, restore the normal Milo. As far as treatment of delayed puberty is concerned, whatever the cause might be, whether it is central or peripheral delayed puberty, treatment of choice is estradiol. We generally do not advise pulsatile GnRH therapy, unlike in the males, because it just does not work in females. We do not have validated data for this. It is either with an estradiol valerate or an estradiol patch. This needs to be started slowly and gradually escalated over a period of 24 months, because estradiol is essential for breast development. If you are too rapid with your estradiol therapy, the patient might end up having menarche very earlier, but the uterus is going to be small in size and the breast development is also going to be minimal. So you have to escalate it, and the minimum time period you need is 24 months. You start progesterone only when the breakthrough bleeding has been established, but before you do that, establish that the breast development has been adequate. Growth hormone therapy is indicated in children with Turner syndrome and combined pituitary hormone deficiency. Last slide, coming back to your case. She was evaluated and found to have a normal bone age. The LH was 35 and the FSH was 45. Estradiol was 14, just slightly quite low for the age. Slight hypothyroidism. The karyotype turned out to be a Turner variant, X chromosome long arm deletion. She was physically without any Turner's phenotype. She was started on estradiol. The mid-parental height was 166. She was already at 152. So this was where we had a contention about should we offer her growth hormone therapy or not. The reason is she was offered growth hormone therapy because, one, her mid-parental height is quite high. And the second thing is there have been a few studies which actually tell us that growth hormone is essential for development of proper endometrium in the uterus. This girl, with the future advances in medicine, can go on to have assisted reproduction with ovum donation. And if you do not start her on growth hormone at this point of time, the uterus might not develop enough to support reproduction at a further point of time in life. And that is the reason why even in assisted reproduction, people are using growth hormone. So it did make some convoluted sense to start her on growth hormone therapy. It was offered to her. She did take it, and her eventual height ended up around 165 centimeters. To conclude, this is what I would request you to look at a case of growth, delayed puberty. First, look at the definition of delayed puberty. We get a lot of children who present to us at 11 and 12 years with no onset of secondary sexual characters. They are still not within the 2 standard deviations for that age. Wait till they cross 13 years. Look for physiological variants like CDGP and functional hypothalamic amenorrhea. Evaluate responsibly. Like I said, don't rush into investigations in step 1. Don't do an exome sequencing on the first day of the visit. Wherever you are, whatever you do, suspect Turner syndrome because it is much more common than we think it is in the general OP. Treatment should be escalated. When you start treatment, it should be escalated slowly. Too rapid treatment is going to impair her future reproductive potential. And most important, this estrogen therapy is not going to help her with reproduction. Once the child gets married and she wants to reproduce, she should be educated that she needs further fertility therapy. She will need gonadotropin treatment or JNRH treatment, and she should be referred to an appropriate center which can handle this kind of cases to ensure that she has a successful outcome in reproduction also. Thank you, and if there are any questions, I'd like to take them.